Hello, everybody. Welcome to this lecture on Chapter 3. It's Mr. G here. Um, I told you that I'd be recording some of these for class this month. This for our Strength and Conditioning, National Strength and Conditioning Association book, the Certified Special Population Specialist, Chapter number 3 here for this book. Now, obviously, I have the camera on. I'm not going to do them all like this, but I wanted to do this one so I could show you this option. Because you all have to record your lectures. Well, not lectures. You're recording your project presentations this month. So this is what it looks like with the camera. And this, again, is Microsoft PowerPoint that is provided to us through Kaiser University. Now, I have a fancier microphone and things like that I can use for higher quality audio. I didn't even use it for this. I just wanted to use my standard laptop one. Very easy to do. And actually, when we're in class on Thursday of this week, I'm going to show you how to do this because I know some of you are not as familiar. So we'll get going through this. We're going to go over musculoskeletal conditions and disorders. That's going to be our topic for Chapter 3. Okay, here we go. So let's start with disorders of the spine and the associated musculature surrounding the spine. Lots of different reasons that this might happen, and the causes and symptoms are difficult to define. Now, treating with exercise is going to be individualized because not all back pain and issues involving your back are going to be the same. Included, though, are going to be low back pain, which is always a big topic, and postural disorders, things that we've talked about at least in assessment classes and some of our other courses. So let's start with low back pain, our first condition that we're formally tackling this month. It's defined quite simply as pain and discomfort localized below the costal margin and above the inferior gluteal folds with or without leg pain. So it might not include leg pain. It might, obviously it's in the lower back region, so that's what it's talking about. If the cause is unknown, which for most people it is, it's referred to as nonspecific low back pain. It is characterized by its duration, so that's how it gets named. So 3 classifications here. Acute low back pain is going to be less than 6 weeks. Subacute is between 6 and 12, and your chronic back pain is going to be 12 weeks or more. In developed countries, so countries with money and technology that are doing what I'm doing right now, which is sitting down to talk to you, it occurs in 58 to 70% of people, and that number goes up as people get older. The result is that this is a very costly condition to be afflicted with because everything that goes along with it. You go to have the doctor's office more, so medical office visits cost money, medications cost money, surgery, diagnostic tests if you need x-rays or CAT scans or anything done to kind of look at the bones or look at the muscles to see what's there. Your travel costs to doctor's appointments. And this is just at the individual level. There's also associated costs in terms of productivity for businesses, because if you're missing work, well, then that's lost productivity there. Maybe you're not as efficient with your work if you have low back pain. It's a costly problem, and it's very, very common. The onset of it is associated with a number of different things. I mentioned one being, just technology and sitting down a lot, but other physical attributes like age, which we mentioned, weight, how heavy you are, your height, fitness level, so how fit you are. These are all things that can impact the likelihood of low back pain. Occupational hazards, so it's not just for people that sit down all the time, but people that are in highly demanding jobs, things that have a high physical demand. You're doing a lot of heavy lifting, whole body vibration. Like, these are all reasons, ways to throw your body off of normal alignment and put lots of stress on it. So there's reason to possibly incur an injury as a result. The body structures that are affected include your intervertebral joints or discs, your surrounding musculature in the area, your components of the nervous system, so actually your nerves can be affected, and that causes variability in the symptoms. So it's not quite the same for every single person that is afflicted with it. When it comes to medications, and let me start with talking about why we talk about medications here. Now, obviously, we're not doctors, and no, I'm not looking for you to memorize all the medications that are there. But here's the thing. when you have a client that comes to you and they are on some type of medication, they're going to put that down in all of their pre-assessment paperwork and in their medical history, all that stuff. The reason you need to have that information is because while you don't have to memorize it, you should go and look up to see what these medications do, because they do have physiological impact on the body, and there are certain exercises that are not recommended or are contraindicated as a result. So you knowing what those medicines are, what types of medications they have, that's going to help you to come up with a better selection or a better process of programming for that individual, because certain things you can't do just based on the kinds of medication that they have. So make sure that you know that, and then just know where to go. That's the biggest thing. You don't have to memorize all this stuff. No one's expecting that of you. You got to know some of the major classifications and what things are, but you don't have to be a dictionary on it. But you do need to know where to go, where to look it up, so that you can help people the right way. Side effects that go along with some of this. If you have take any NSAIDs, which are your non-steroidal anti-inflammatory drugs, otherwise called NSAIDs, like Advil, Aleve, Motrin, very commonly prescribed, and some of it's over the counter. So that's something that you can use there. There are no short-term effects on activity, so it can help you get back to being active. But in the long term, especially if you continuously take this medication, it can slow down muscle regeneration. And other long-term effects that might come along with it are gastrointestinal discomfort, possibly some kidney dysfunction, and then an elevated risk of heart attacks and strokes. So taking any medication, while it might alleviate pain in the short term, there's consequences, and that's why we're talking about exercise this month as medicine, essentially. How much better off you will be, because all your aches and pains, you can help to alleviate them by having a strong body. You can also take some non-opioid analgesics like Tylenol, and there's no necessarily known side effects there for Tylenol. It's not considered as strong. But I can tell you, going back to the NSAIDs, Advil, ibuprofen, that kind of stuff, I used to take that as a painkiller quite a bit when I was in high school, because, silly enough, I didn't wear my glasses when I was in school. And because of that, I had issues with my vision. I had trouble seeing. And rather than wear the glasses or go get new glasses, instead I just squinted at everything, and it gave me headaches every day. And with those headaches, I started taking some non-steroidal anti-inflammatory drugs, and what I wound up doing was actually like tearing up the lining of my esophagus. So actually taking too much of those other medications is no good. I switched, I fixed the issue. I wear glasses and I don't have that problem anymore. But whenever I take painkillers now, because I had such a bad experience with it, I do take Tylenol, because it does not give, I don't have those same side effects. It hasn't caused me any damage in the lining of my stomach or my esophagus. So a little personal note there to kind of give you some insight as to why you might take something or not. There's other things that you can use, anti-inflammatory patches. There are muscle relaxants, and some of them are pretty hard, some hardcore stuff like Valium. And again, these types of medications, be careful. They can cause dizziness, drowsiness, and those are things that you should know about with your client if you're going to be giving them exercises to do. And this one I thought was interesting. I was not previously aware of this, but giving someone SSRIs, and SSRIs are really generally used to treat depression, but they, I guess, are used in association with low back pain. Maybe someone is depressed because of low back pain, and things like Prozac, Zoloft, Paxil, antidepressants. Those can cause mild dizziness, drowsiness, and negatively affected coordination. So those are also some considerations for when you're going to be working with these clients. All right, moving on. The recommendations are going to be summarized. Now, I'm not going to read you verbatim here, but here's a little quick snapshot for you. Folks, again, this is a hybrid class this month, and I am expecting you to sit and listen to these, go through them. They will take the place of us having to sit in class for 5 hours a day, 4 times a week. Instead, we've got 4 hours a day, twice a week, so that we can actually do some more practical hands-on stuff, and I can help you with some of your more major assignments. But you are going to need to have this book, crack it open, and go in here, because you are still responsible for all of the information, whether we talk about it or not. That's kind of part of your studies for this course. So make sure that you're doing that. And of course, if you have questions or you need me to help you add anything, please come see me, email me, talk to me. We'll figure out a way to get you everything that you need, but you do have the responsibility of taking it on. Now, a couple quick recommendations here. Resistance training for low back pain should be focused on abdominal and lumbar strength using 1 to 4 sets, 8 to 12 reps at a low to moderate intensity initially, and then obviously you would progress over time as tolerated. Include flexibility training that targets trunk and hip musculature using a minimum of 3 sets for 10 seconds. That's one of their recommendations there. And aerobic training should start with short bouts of up to 30 minutes a day. Again, that doesn't have to be 30 continuous. You could do short bouts. You could do 5 or 10 minutes at a time, but get up to 30 per day, 3 times a week, up to that 150 minutes a week. Maybe possibly 300. Again, getting your body used to moving so that it doesn't have as many problems with moving anymore that might cause some of that low back pain. If instead your low back pain increases, then you will want to actually terminate the exercise and not do it, because if that's going to be a contraindication. If you are getting hurt worse, stop what you're doing. Pain is a sign of something wrong in the body. You know, I know any of our Marines and some of our military folks, pain is weakness leaving the body. Not so much. There's such a thing as the pain that goes along with acute soreness after a workout. That's usually to be expected. And then there's pain, real pain. And if that's what you're experiencing, you need to pump the brakes and stop what you're doing. Postural conditions. This is something that we as a group haven't talked about in a while, but you have had some work on it. If you've taken corrective exercise in the past, or even when we did our personal training course, those types of classes are going to tell you a little bit about postural assessments. So we're going to revisit some of those concepts here, because those cause a lot of the issues that we're focused on as part of this chapter. Your posture is the alignment of your head, neck, trunk, and limbs within space. And we know that there's a proper posture that everyone should maintain. Now, it's analyzed both statically, so while you're standing still, or dynamically through movement. Good posture is defined as the best alignment that allows the most efficient movement of the body without undue stress on the musculoskeletal or nervous system. So just the way that your body can do its best work. Postural assessments, so things that we have done before. In fact, I'm standing in front of where we have our plumb line, which you can see right over here. Well, sort of, if you can make it that far. It's kind of small here, but over here on this side of the room. And then also things like the overhead squat test. Not to mention, last thing here, just because you do it in an assessment doesn't mean that's the only time you're looking at posture. This is why we cue exercises and make sure that everyone maintains proper body alignment in order to make sure that the thing happens the way it's supposed to. You should always be assessing and analyzing your client's posture, not just in the assessments that happen every so often or prior to you working with them in the first place. Figure 3.2, which I think is on the next slide, as a matter of fact, and it is in your book, located on page number 73. The spine does have a natural curvature, which we know. We have the lordotic curve, which is at the low back. That's a concave curve. Where's he at? You can see over here. Wheel our little pal over this way. See, this is one of the benefits of having video, is you can actually do this sort of thing and include some visual demonstrations as well. So you can see we're looking at him from a lateral view here. So you can see that his spine is going to have these curvatures that we're talking about here. We've got his lordotic curve, which is a concave where it goes inward curve on the low back. And then we've got the kyphotic curve up at the top. Kind of makes like a letter S, but very slight letter S, if that makes any sense. We don't want it to be overly exaggerated, like too much kyphosis or too much lordosis, because those are going to be the postural deviations that we're concerned with as being problematic, and that's what we're getting into now. Too much of those curvatures We usually just call them kyphosis or lordosis, but again, we mentioned there's a natural lordotic curve, there's a natural kyphotic curve in the spine. Hyperlordosis and hyperkyphosis, otherwise known as lordosis and kyphosis, are those postural deviations that are not so good. Scoliosis, on the other hand, is when that curvature is not exaggerated along the lines of the normal curvature, but instead it is pulled off to one side or the other. It's excessive mediolateral curvature, so the direction of the spine is pulled in opposite direction of what we would see in the hyperlordotic and hyperkyphotic, which you can see here. So again, here's that example that lines up with the skeleton we have here, but the hyperlordotic curve, something that we see especially in pregnant women, which when we get to that part of our studies, we'll talk more about why that happens. I know I've done plenty of examples on it, so you should be familiar with why that would increase that lordotic curve. You've also got hyperkyphotic, that's what that looks like. And then over here to the right, that's your scoliosis. You see how the spine is actually pulled in this direction where it's no longer here. Is this going to work for me? Let's see. Highlighter, pen. Nope. All right. Well, anyway, you can see my pointer, I think. Usually the spine should be right here, but instead it's pulled way off to the side. And notice we can't analyze that from a lateral view. We're seeing that from a posterior view, and that's how we're able to assess it here. So things that might cause that hyperkyphosis, it's something that actually is pretty common, is becoming more and more common now because of just the way we are on our phones all the time and sitting all the time, because we sit kind of the way I'm sitting right now as I'm getting too close and I'm slumping over and I'm kind of exaggerating the curvature in my spine up at that kyphotic curve. Possible causes can include some comorbid conditions, so other problems that you might have, like arthritis or osteoporosis if you've had an injury to the spine. Those are all things that are separate issues and things that we will get to this month, some of them even today. But other things like prolonged sitting or slouching, so having poor posture while you're seated, sitting down too much, those are things that actually can include it. Because of maintaining this bad body position for long periods of time, it's going to cause some of these issues. When it's severe, it can actually result in nerve impingement, so it can actually affect other areas of your body when it starts pinching off those nerves. That will cause pain, or it might cause other pain in other areas, and possibly even impaired lung function if it's severe enough and interferes with your lung functioning. There are some corrective exercise recommendations, and what I would like for you to do, because you should be listening to this, I would like for you to send me an email by Monday of week 2 that has the recommendations that we talk about on page 74. So do me a favor. Don't tell your classmates about this assignment. This will be a lab grade, and we're not done yet, so make sure you continue watching this video. And I'm going to do these throughout the videos that I'm going to be recording this month, just to make sure that you guys really are listening to it, at least with one ear. So once again, we do have a little hidden assignment here, an Easter egg, if you will. I want you to go to page 74 and tell me what those recommendations are for the thoracic hyperkyphosis. In the case of lordosis, possible causes here, again, things that you might not be able to help, other things that you might be able to help with. Things like cerebral palsy, muscular dystrophy, those are issues, osteoarthritis, that you can't really do much about. Pregnancy as well, although I would say you do have some degree of control over that. But things like obesity and prolonged sitting, wearing high heels, these are issues that are lifestyle related. So that's something that can also cause this problem. It increases the risk of injury to lumbar structures and often causes low back pain, which is why we talk about it here shortly after the low back pain section. Spondylolysis, and or spondylolisthesis are also issues that might be prominent with hyperlordosis when you're working with other injuries that might occur to the spine in the lumbar region. So keep that in mind, that this lordosis can actually lead to those other issues as well. Again, Along with what I asked you to do, this is also on the next page here. It's right on 74. Those corrective exercise recommendations. I want them for both the kyphosis and lordosis. Again, this is why I want you watching this. So make sure you send me an email by Monday morning when we start class at 9 o'clock. And do me a favor, don't share this with the other students. You get credit for what you're doing. Don't spoil it and give it away to others. Make sure that they're watching it too. They shouldn't get the benefit of the work that you're doing because you're doing what you're supposed to be doing. I want to make sure that everyone is taking part in this class to the fullest capacity as a hybrid. I know we're not in class, but that doesn't mean these days are free and that you don't have to dedicate time for your stuff. Scoliosis, what causes it? Sometimes it's unknown. It might have structural causes, like if you have a structural leg length discrepancy, something that you were born with, or if you have any deformations in your vertebrae in the spine. These are issues that can cause it, and they're something that are just part of how you were built, how you were designed. But there's also functional origins, and these have more to do with leg length discrepancy that might be because of muscular issues in the area too. So actually injuries and posture and those types of things can also impact leg length, and then that could throw off your body and cause this problem. So that's something that there is actual corrective measures that you can work with in order to employ and improve scoliosis. Now, what can happen if you have this? It can have impaired respiratory function, so your lung and breathing capacity, pain, reduced physical function and movement capabilities. I mean, go back and think about what that looked like on the slide we just looked at, where how it kind of looked way off to the side. Do you think, if that's what you have going on, that you can move quite as well as someone that has a normal curvature? Biomechanically speaking, you've got some issues here that might limit mobility and might impair physical function, generally speaking. So those are some of the issues to be concerned with if someone is afflicted with scoliosis. Now, if they're going to work with you and they're going to use corrective exercises, this is not a spot where you just look in the book and start doing something. You're going to need a doctor's medical clearance for this. So that's a little bit outside of our scope. There's more that needs to be done there. Moving along here, let's talk osteoporosis, something that comes up from time to time in our classes, but this is the course where we would talk about it the most. And it's a term you've probably heard of. It usually gets associated with older folks. It's defined by the World Health Organization as a bone mineral density. So how dense your bones are. It is 2.5 standard deviations or more below the young normal adult score. So they've taken the score of how dense everyone's bones are supposed to be, and they've come up with a norm. Now, that norm fluctuates. You want to be, everyone is within range of it to some degree. But once you get outside of it, which you get a little bit lower by 2.5 standard deviations, which is a pretty significant deviation away from what the normal is, that is considered to be osteoporosis, and your bones are more brittle. They are not as dense as they were. It reflects an imbalance of bone remodeling. Remember, bone gets broken down and rebuilt just like other cells in the body. So there's more bone resorption. So that term bone resorption is when osteoclasts, those come in and they break down the bone and they release more calcium into the bloodstream. And then rather than your osteoblasts coming in for bone formation. Typically, this stuff happens normally as you're a younger adult, but as time goes on or other issues that we'll talk about here in a minute get in the way, that resorption component is stronger than the remodeling, than the formation. So the osteoclasts are going to be more active than the osteoblasts. Osteoblast, B for building, which is kind of the opposite. You think blast usually sounds like destruction. It's not. In the case of bones, a blast is a good thing because it's building. It's blasting some new bone in there. Osteoclasts are actually taking them away, taking it away and breaking it down into calcium in the bloodstream, which is not the ideal set of circumstances. Now, primary osteoporosis is actually categorized down into two different types. Usually occurs due to age, and it's actually far more likely in females, so an 8-to-1 ratio. So ladies, you have more concern with this issue than men do. And we'll talk about why here. Type 1 osteoporosis, otherwise known as postmenopausal osteoporosis, usually occurs between the ages of 50 and 65, because that is typically when women will go through a rather significant change in their bodies, and that's going through menopause, where they no longer are going to have their menstrual cycle. And when that happens, the amount of estrogen that's produced in the body is going to be really diminished significantly. And estrogen is tied to that bone health for women. So when it is taken away, bone health suffers as a result. And what that results in is, during that initial period of postmenopausal time in someone's life, there is a 5 to 10% loss of cortical bone, and 20 to 30% loss of trabecular bone over the span of 4 to 10 years. So that's a pretty significant thing to know about. And you might be saying to yourself, well, hey, what can I do? Because this isn't really talking a lot about the prevention aspect. But what I can tell you is this, especially for the students we have in our class at this time, 20s and 30s, some early 20s, we've got some variation in there, maybe up to early 30s. The biggest thing I can tell you is have good bone health while you're young. That is the biggest thing that you can do. And then, of course, stay active throughout your life, because bone formation and that, resorption and the osteoblasts coming in and doing their thing over the osteoclast, by doing more exercise and more strength training and building bone mass, you can help to maintain, and you can help to actually minimize these losses that you see after menopause. But if you don't stay active and you have a lower bone mineral density, or you're not active as a little girl and into early adulthood, you have less stuff to work with. So when you start losing that bone mass, you are more at risk. So prevention is really one of the best things. So if you are a woman, it's something to be concerned with. If you have little girls especially, that's the biggest thing I can tell you, because I've got little girls too. Keep them active, get them strong, get them strength training, get them bouncing, doing load-bearing and weight-bearing activities, because that's going to build their bones nice and strong. And then by the time they get into their 30s, where they reach that peak bone mass, you want that to be as high as it can possibly be, so that they don't have issues with losing too much bone mass, and they're more protected against developing this disorder. Type 2 osteoporosis is what occurs after the age of 70, so this is not just postmenopausal anymore, but it's a slower loss of bone. So we're only looking at 20 to 25% loss of both bone types during this time, as opposed to the widely varying issues that go on in that postmenopausal period. But it's still an issue. Again, prevention is key, and maintaining good bone health. Secondary osteoporosis, which is sometimes called type 3, it's initiated by the presence of other diseases. So this is not necessarily because of age. Now, osteoporosis is primarily related to age, but in some situations, in some cases, it has to do with other things that might be going on, like cystic fibrosis. If a woman has anorexia, or if she has the female athlete triad, which disordered eating is a part of that, so they're not getting enough nutrition, and their body weight gets down very low. And when body weight gets down very low, what can happen is that women will actually stop to have their menstrual period. They will stop that menstrual cycle, and that affects that estrogen level. And we talked about how estrogen is actually related to bone health. That might actually cause the onset of some damage to your bone health, and possibly up to including osteoporosis. Other medications can cause it too. So things to be worried about. What does it mean? Okay, now we know what it is. Besides the increased risk of bone fracture, because now your bones are more brittle, they're not as thick, they're not as strong, and postural concerns that go along with it, such as thoracic kyphosis, osteoporosis is also linked to higher morbidity rates. And that term, morbidity, I think I've even said it here before, just to kind of give you a key term, because you'll hear it. That word morbid, when we think of it, we usually think of, it's usually used in the context of something like gruesome and scary, and usually having to do with death. But in the case of actually using it in science, that's not the case. Comorbid conditions are things that happen together. So morbidity means you might have another disease or another disorder that goes with it. Mortality rates means death. And with osteoporosis, it is linked to higher both morbidity issues, morbidity rates, and mortality rates. Common medications for this: They've used hormone therapy. Excuse me. It used to be the most common medication, but that's changing a little bit because of the possible link to increased breast cancer, blood clots, and stroke. So this might not be the best way to go. Risk factors for cardiovascular disease and breast cancer should be assessed before you use any of this hormone therapy. Then there's other things like selective estrogen receptor modulators, which leads to reduced bone resorption, which that's good because we don't want to lose bone mass. We don't want bone cells to be broken down, but it might cause stomach issues, some gastrointestinal distress issues. There's no free rides with medication. There's no magic pill that fixes everything. There's always going to be side effects. So if this is an issue that someone is facing, and this is one of the options that is presented to them, that's one of the consequences of taking this medication. Now, where do we come in? Exercise. Moderate to high intensity weight-bearing exercise, both aerobic and anaerobic exercise, is the most beneficial because it will do the most to maintain good bone health. Lower intensity exercises may be recommended for those who have very fragile bones, right? Because then we can't do those more intense versions of exercise. What it can do, it'll actually help to not only increase muscle strength, which we know strength training does that, but it also increases your bone mass. And it can also improve balance and proprioception issues. And that's good because with this disease, you also have an increased risk of falling. And then you have that increased risk of falling means it's more likely that you're going to break a bone because your bones are brittle. It is a vicious cycle. So stay active. And if you're working with someone there, use these recommendations, go off their doctor's notes as well, and help them as best as you can so that they maintain good. Recommendations are in here. Table 3.3 is on here. That's on page number 79. Screening, though, for osteoporosis should include the following: evaluation of other fractures that limit exercise, muscle weakness and muscle imbalances, balance or coordination issues, other disease states, any medications that they're currently taking. We already talked about what some of those are and what they might affect. How severe is this osteoporosis? That will impact the level of intensity that you're going to use with them. Make sure, again, that you obtain medical clearance and practice some good ways for precautionary measures to prevent falls from occurring. If someone has that mild to moderate osteoporosis, here's some basic recommendations, and they're going to sound a lot like the normal ACSM standards, which is great. Weight-bearing activities like walking or running, right? You won't want to actually put someone in a pool here necessarily, because when you put someone in a pool, you eliminate gravity. So now they're no longer putting any stress and strain on the bones, so the bones don't have as much room to grow. So walking or running, weight-bearing activities, 3 to 5 days a week at 55 to 75% of your max heart rate, or for about 30 to 60 minutes per session is recommended. Light intensity and low or no impact exercise such as walking and swimming are recommended for those who have severe osteoporosis, because those do have benefits, but for someone that has mild or moderate osteoporosis, it's not going to help them quite as much. If they can withstand it and tolerate it, then we can actually put their body in a state where we're going to actually help to maintain or possibly even increase that bone health. Resistance training, so we talked cardio, 2 to 3 days a week of resistance training using 2 or 3 sets, 8 to 10 reps, looking at between 60 and 80% of their 1 rep max. So we're doing some serious training here. You got to monitor balance demands, right? Don't make it too crazy and don't put them in a position where they're going to fall, but we also want to help improve their balance with lower intensity depending on severity. So the more severe their issue is, the less intensity we go with. Makes sense. Flexibility training, same as what we do for the normal population, 5 to 7 days a week, but especially in the hip, knee, and the pec girdle. 15 to 30-second stretches are what you're going to want to use. Excessive twisting or flexion of the spine should be minimized, because actually that kind of stress and strain might actually, it can actually lead to fractures, believe it or not, if their bone health is bad enough. Osteopenia, a term maybe some of you have heard. It's kind of like the precursor to osteoporosis. So while osteoporosis was 2.5 standard deviations or more away in terms of lower bone density, osteopenia is between 1 and 2.5 standard deviations below that young normal. And it is kind of like pre-diabetes or pre-hypertensive. You're not all the way in the bad just yet, but you're getting there, and you have a higher risk of becoming osteoporotic if you don't do something soon. Younger women it can happen in, so this is not just going to be relegated to women in their 50s and 60s and 70s that are postmenopausal. This can happen in younger women and is very common actually in certain types of athletes where women have very low body fat. Anorexia, poor nutrition, amenorrhea, some of these actual sports and activities that require women to cut lots of weight and actually eliminate a lot of their body fat percentage, that gets in the way of normal functioning. And when, again, that estrogen gets depleted because of the cessation of a menstrual period, those are things that can actually cause more problems and can lead to bone health issues earlier on. Interventions made soon after diagnosis can actually reverse or slow down that progression towards osteoporosis. The impact, very similar. Always take precautions against high impact activities when you're dealing with bone health. Intensity is good, but high impact, be careful. You don't want to cause fracture. Arthritis. So we went from osteoporosis to now talking osteoarthritis. This is a degenerative disease, and it causes pain, swelling, and decreased range of motion in the joints that are affected. Knees, hips, hands, and spine are going to be your most commonly affected areas of the body when it comes to having arthritis. Just like with osteoporosis, women are going to be at more risk than men, with the risk, again, also increasing after the age of 50. Same reasons that we said for osteoporosis. Now, the causes of this, though, are largely unknown, but structural misalignment, muscle weakness, excessive body mass, these are all things that might have something to do with it. It's something that these are issues that are common with folks that do have osteoarthritis, but we don't know exactly. We just know it's an issue, and we do have some recommendations on how you should handle it and how you should work with somebody. Some quick stuff here on medications used primarily to treat the symptoms, which are usually pain. So NSAIDs, other non-opioid analgesics, glucosamine, chondroitin supplements, topical analgesics, so things that actually numb the pain, dull it. Other medications might reduce inflammation, or they might attempt to improve joint function, and those might be your corticosteroids, so getting like a steroid injection or a hyaluronic acid injection, and this is to help with lubrication and shock absorption in there, because remember, that's what our cartilage does in these joint capsules that we're talking about, and that's what's going to get worn away and cause that inflammation and the issues that result in this osteoarthritis. Exercise, believe it or not, can actually help with joint pain reduction. It can help to improve joint stability and can counteract muscle weakness, and these are all issues that are contributing factors to this being a very, very problematic disorder. Table 3.4, page 85. So skip a few ahead here, and table right at the bottom of the page, that's going to give you an idea as to some of the things that you should do. Aerobic exercise with large muscle mass, including swimming, cycling, or walking 3 to 5 days per week at light to moderate intensity for 20 to 30 minutes. You notice that walking is not going to be tremendously load-bearing. It does have more load-bearing than the other options we mentioned. Swimming and cycling, swimming really gets a lot of that. And if you're having issues with the joints and inflammation and pain, this is what we're doing to kind of help alleviate that pain while still giving you the opportunity to grow and get better. Resistance training 2 to 3 times a week, just like with normal exercise. Same thing. I mean, all this stuff, look at it. It sounds a lot like the normal range of things. You're just altering the intensity and the modality, the type of exercise that we're doing. And this is really how things are going to work for all of the disorders and diseases that we have here. The principles of exercise selection creating this program are the same. Your limitations and things that you need to consider are different, and that's what we need to be aware of to help these people most effectively. Sprains and dislocations. I'm not going to spend a lot of time here because we've done this in injury prevention classes, sports medicine and first aid. Joint sprain is damage to ligaments. One of the most common joint disorders. Again, that inversion ankle sprain is number one. You might also see sprains in the knee or the wrist. There it is, that lateral inversion ankle sprain. Basketball, football, soccer, anything where you might roll your ankle. Joint dislocation, so if a joint actually comes out of alignment, when those joint surfaces get separated from one another, pain, limited range of motion, numbness, tingling, these are all going to be some of the symptoms that happen after a dislocation. And the shoulder is the most commonly dislocated joint in the body. 71.8% of all dislocations right here at the shoulder. Sprains can be categorized by severity of stretch and the degree of resulting instability. So we've got grade 1, 2, and 3. Grade 1 is minimal, no tearing, no instability. It's just painful. Grade 2, you're stretching out that area now, and now there might even be a little bit of tearing, and now the joint is no longer as stable. That connective tissue, the integrity of it has been damaged. And grade 3 is a complete tear of the ligament. And there is a significant disruption in terms of the stability of that joint. More often than not, grade 3 sprains are usually going to result in the need for surgery. So like when you hear a lot of your athletes, football players, baseball, basketball players, when they go out with like, oh, I tore my ACL, my MCL, and I tore this, I tore that, we're going to be out 6 to 8 months. This is what we're talking about. Dislocation is usually caused by an impact or by falling. Excuse me. By the way, guys, don't do this while you're recording your presentations. Do as I say, not as I do, right? No, well, this is a much longer presentation than what you guys have to do. And I'm going to try and kind of tighten it up here since this is getting a little bit long, but we're getting closer and closer to the end here. About 2/3 of the way done, and I figured this might take about an hour. I'm going to try and get it less than that. Dislocation caused by impact or falling. The degree of separation, so you might have a subluxation, which is a partial dislocation, or a complete dislocation. It could be simple, so it might just be dislocation. Things are just kind of pulled away from one another, so there's no bone trauma. Or it could be complex. So not only have you had these two components of a joint pulled away from one another, but in addition to that, the ligament has also been damaged. Maybe the bone has been torn away, sheared away. There's some issues there. And then severe. There might be other issues that affect your blood vessels. And so a dislocation can be far more complicated than the way it sounds and the way it's depicted on television. What can you do? Pain medication there. Effects of exercise. If you do grade 1, weight-bearing exercise after your swelling has disappeared is allowable to improve mobility and strength. You're going to have to get it back to strength after a while. Grade 2 and 3, you're going to need to immobilize longer, probably much longer. And then a treatment by a physical therapist is going to be necessary. We have some recommendations a couple pages down the road here on page number 90. When it comes to dislocations and sprains, again, this is going to be more minor here, but you're looking at full rest for about a week. Then after that, work on restoring your flexibility, the full joint range of motion, strength for about 1 to 2 weeks, low to moderate intensity body weight exercises, 6 to 7 days per week. So you're really doing some heavy rehab here. You got to work that joint to get it back to what it was doing. But you're only looking at things like body weight exercises, low to moderate intensity, getting the joint used to the normal stresses and strains of you and your activity of each and every day. Then once it's pain-free, because pain-free is the biggest thing, that means we can get back to work. Then you can go into strengthening, low to moderate joint range of motion exercises, 6 to 7 days a week. Moderate resistance can be added 3 times a week. So as we get further on, it gets more progressive, but it has to be pain-free before you can really start getting yourself back to being on-field ready. Now, what if someone has had a joint replacement? This is more complex. Joint replacement surgery usually involves replacing a damaged joint with some type of synthetic prosthesis, so a prosthetic, so a fake joint or a fake limb. in order to improve function and eliminate pain. Usually pain is one of the issues, and then help to improve function as well. Osteoarthritis, believe it or not, going back to that, is the principal cause of hip and knee replacement surgeries. This bone just kind of rubbing together, all that pain and inflammation, that doesn't really lend itself to a very efficient life. So replacement might be necessary as a result. You might get pain relievers, antibiotics, anticoagulants, which are going to be blood thinners so that your blood does not coagulate and actually cause blood clots, because that can cause a whole other slew of problems. Exercise. So after joint replacement, believe it or not, physical activity is recommended, because what it does is, as you exercise, your blood flows more efficiently into more parts of the body. Stimulating that blood flow will help to actually reduce the incidence of blood clots, which, believe it or not, occur in 40 to 60% of joint replacements. So that's a pretty high statistic. When it comes to getting back to work, getting back to exercise, again, page 93, you got a nice little table here. And these are the kinds of tables that you'll refer to. That's why this book is one that you should keep in your collection forever, especially if you're going to be working with patients, because it's a quick little reference to tell you the types of things you can do with people depending on the issue that they have. Stable, pain-free movement under supervision of a physical therapist, then they can get cleared and come and see you to begin that resistance training program. Even after they're cleared, low impact, very simple aerobic exercises, walking and cycling are going to be your primary choices there. After 6 months, then you can get to moderate to vigorous intensity exercise on an individualized basis. So based on their tolerance, again, keep them pain-free, keep them safe. Don't push them too much, and don't let them push themselves too much. You are the expert. You want to monitor it on an individual basis. No two people with this joint replacement surgery are going to be the same. Frailty, which I believe is a movie title, but we're not talking about that. That occurs in older adults, and it's from a combination of things. Just poor general health, muscle strength is affected by that, reduced ability to engage in physical activity, or your ADLs, your activities of daily living. That's what frailty is not being able to do very much, being weak, and it might be because of poor health. 20 to 50% of individuals aged 85 or older are likely to experience frailty. That's a big range, 20 to 50%, but 85 is pretty old, and we've already talked about what issues happen with advanced age, and there's a lot more to it than this. This is a rather brief explanation of some issues that plague older adults, but when you think about all that together, it makes sense that this can cause frailty, especially as that age gets up there, because 85 is getting pretty old. Result of age-related decrease in functionality of organ systems, and it's made worse, again that word exacerbated, it's made worse by nutritional decisions that might not be so good, and environmental factors and coexisting disorders. So if you have any comorbid issues like osteoporosis or osteoarthritis, things that are painful, that are uncomfortable, that maybe make you not want to work quite as much and get up and move, well, those kinds of things can also go along with just the process of aging, which we're going to talk about with sarcopenia in just a minute. Frailty, lots of different medications. Find out what they are, look them up, know what their side effects are, what they do, any risk related to physical activity. Make sure you screen everybody, especially if you're working with an older population. They're going to have a full menu of the exercise, not the exercise, of the medications that they have. Get with their doctor. This is what we're talking about here, especially in this class where we're talking special populations. You want to have that good communication with their primary care physician or their doctoral team. You're going to need to know what they're allowed to do and what's recommended, and then you're going to supervise it and make sure that it happens. What can exercise do for someone that is frail? Well, it can make your life better. You can be more functional. More neuromuscular coordination so that you have better balance and less risk for falling. We already talked it might be comorbid with other issues that could also be affected by that. Increased muscular strength, power, and mass to reduce the risk of falling. So there's lots of good reasons to do this. Better cardio functioning to attenuate cardiovascular disease. So you see how if you're frail and you can't move, now you're not doing anything for your heart health either. Everything is connected. These things all go together. Just staying active and healthy making sure that you're doing your flexibility exercises, your cardio, your strength throughout all stages of life. These are going to cause you, well, they're going to prevent you from having a lot of these issues that are sadly all too common in people as they get older. And medicine's keeping us alive longer, and now we're dealing with all these issues on top of it. That's not necessarily living better. Doesn't mean you can't, but this is what you need to do if you want to. If you do any fitness testing or someone that's very frail, medical supervision is a must. Aerobic training, just like you might think, start light, maybe moderate, maybe 5 minutes per session, 3 minutes per day. Again, they're very frail, they're very weak, they don't have a lot going on. 5 minutes is more than enough time. You do that up to 3 times a day, that's 15 cumulative minutes. Large muscle activities, walking, swimming, biking, chair exercises, all good choices. When it comes to resistance training, light to moderate intensity, 3 days a week. Include neuromuscular and flexibility training on most or all days of the week to improve coordination and balance. It doesn't mean have them do a step-up curl to press where they're balanced on one leg. You can do things on the floor that cause them, and maybe put them on a foam pad or raise one leg, or there's a number of staggered stance. There's a number of different ways that you could help to actually improve balance and coordination. Go back to what you've learned. Go back to our NASM books. We even did some of it last month in the AFA class that we did, where we talked about progressions and regressions for exercises and things that you can do to make things more challenging and to work from a neuromuscular adaptation standpoint or coordination and balance. You can get creative while still being safe. However, if they have nutritional deficiencies, which is usually hand in hand with this, they eat poorly, get them with someone else, registered dietitian. Seek out people in your community. If you live here, well, we work with the dietitians of Palm Valley. We have them come in for both of our nutrition classes. So if you've had any nutrition classes with us, you've met at least one registered dietitian. They give out their business card. This is why it's important to develop this professional network so that you know who to send people to. Sarcopenia, I told you we would get to this, and we're getting towards the end here of this particular chapter, which I'm sure you're all glad to hear as the clock rolls on. It's a gradual loss of muscle mass and strength as a result of aging. So this is not like atrophy. So when your muscles you lose muscle mass and strength because you're inactive, that's just because you're inactive. This is the age-related process. Inactivity is still part of it. Poor nutrition is also part of it. Chronic disease, so other diseases that you might have can lead to this. Lower anabolic hormone levels, so now you're not building as much mass to begin with. Your muscle protein synthesis, so synthesizing proteins to actually add muscle mass, that capacity diminishes, and that's an age-related process. And then actually spontaneous muscle denervation, so the loss of nerve sensitivity, possibly due to injury or other conditions. So there's a lot that's working against you as you get older. I guess that's what we're learning in this chapter. Lots of meds here. First of all, make sure they've got all their vitamins and minerals. Like look at their carbohydrates, proteins, make sure they get enough calories. A lot of people don't, and there's not as much appetite, and people don't pay attention to those macros. Might see people actually getting testosterone or other androgenic substances, HGH. These are things that can improve muscle mass increases. And we know, just like with anything, exercise to the rescue, it can help to reverse or slow the effects of sarcopenia. Resistance training should focus on type 2 muscle. So with advancing age, pre-existing conditions should also be considered. That's why we do a pretty comprehensive health history. Modify, modify, modify. Take the right precautions. Know that their muscles are not going to be as strong or as large as they once were. So take it down a notch, get them to an appropriate intensity. Again, you're going to have to work through that on an individual basis. And don't do anything super high intensity like 1RM. It's just not safe. It's no good. 2 to 3 times a week, 1 to 3 sets, 10 to 15 reps. So that's more like that muscular endurance range, but that's going to help us get a little growth there, a little more functionality, light to moderate intensity. Aerobic exercise, 3 to 5 days a week, 20 to 60 minutes per session to light to moderate intensity. Again, 20 to 60 minutes. It's all on how much they can actually tolerate. We want to get closer to that 150 minutes a week. That's usually the general recommendation. That's usually the same, and you'll see that amongst a lot of the different conditions we talk about this month. Flexibility also is going to be flexibility and neuromuscular training on individual basis is also encouraged.